And I'd like to open the discussion with Fotis, starting with you, Shak. I just wondered what has been your experience and practice in transcatheter pulmonary valve implantation post-endocarditis.
Post-endocarditis, we've done melody valve implantation in a few cases, and same as what DOF's registry showed, although we got good result, I think about half a dozen of these patients, then there was one at least that I know of who developed endocarditis later on within about a year or so. So generally, we have to look at the risk factors. We have to look at the not just the dentition or dental problems, but some of these have skin problems as well, which are actually under-assessed. And it would be important to really correct some of those possible risk factors.
And would you, in this case, prefer an Edwards valve implantation rather than Melody, as we know that Edwards have a lower incidence of post-implantation endocarditis?
I think probably it's not going to make any difference in post-endocarditis catheter pulmonary valve replacement, although the Edwards Sapien will have or has been shown to have slightly lower incidence. So probably on balance, I would use that now. But at the time when I was doing them for endocarditis related, Melody was the one that was being used most frequently, yeah. So yes, it makes sense to use the Sapien as well.
Okay, and would you, last question for me, would you exclude the vegetation with a cover stent prior to implantation of the valve?
I think, I personally, that's what I would do. I would put a covered stent in, squeeze the vegetation, get it out of the circulation as it were, and then put a valve inside, yes.
Brilliant. Thank you very much. I think that's the way to go. We have discussed this with DOF because we had some cases, and obviously in patients that are high risk for surgery, DOF has been very explicit in that if it is a chronic vegetation, more than 3 to 6 months old, he said you can safely proceed with implantation, which to some patients that are high risk, this is extremely important. Now, Shak, we have a question from you from Christina Trapalis, is a consultant pediatric cardiologist here at ΜΗΤΕΡΑ with us. In terms of sinus venosus closure, Christina is asking, did you have any case, or are you aware of any case of sinus damage and arrhythmia post ASD closure, sinus venosus ASD closure with a stent?
So interesting. The main reason for sinus node dysfunction is because the sinus node artery is external or epicardial, and so it's at a higher risk during surgery. We're putting stents on the internal lumen, and so in none of our patients has there been any evidence of sinus node dysfunction at Holter monitoring 6 to 12 months later.
Oh, that's great and very reassuring. And I think there is one more question, Fotis, from the floor.
From Dr. Vlachos, is there any compatibility with the 3T CMR post-procedure?
No, well, Aphrodite would be the one to answer that one, but our patients have had MRIs 3 to 6 months or up to a year later, and the platinum stents are okay for having MRI, and so it's not an issue.
Yeah, indeed. In fact, we get very nice SFFP images, moving images, and black blood images are particularly important. But 3D, I think it was implied because that with 3D reconstruction, often we get a dropout where the stent is. We see that often in coarctation. So the question probably refers to that. If you can get nice 3D imaging after the stent implantation, I think for that the CT might be better.
Okay, I thought this was about 3 Tesla MRI, but if it's 3D.
Oh, actually, it may be. Is it 3D or 3 Tesla? Oh, I think it may be both. So 3D, I answered the question. 3D, I answered the question. How about 3 Tesla?
That's not, we've not evaluated them on, I don't see a problem with 3 Tesla either, really. But on the 3D front, CT scanning is actually a much better way of looking at the stent without any interference.
Yeah. Okay. Do we have any more questions for this?
I would like to congratulate Dr. Qureshi for his pioneering work on treating percutaneously the sinus venosus defects and keep on going despite the fact that you're stealing cases from the surgeons. And as far as the transcatheter pulmonary valve interventions after bacterial endocarditis, a word of caution for the long-term outcome, but surely if you are dealing with unstable and very sick patients or after multiple reoperative surgeries, this new idea and technology is certainly worth trying and waiting for the long-term outcome of these patients.
I was just given a question for Colonel Austin. Dr. Fanny Papadopoulou is asking why the patients with isolated aortic insufficiency were not offered a David procedure, Colonel?
Traditionally, we tend not to offer the patients who've got severe aortic regurgitation, and all these patients have got severe aortic regurgitation with bicuspid aortic valve, a David operation. Some of the patients who had pure AI had also had repaired aortic valve procedures done at our unit and other units. So it's not just pure bicuspid aortic valve disease as such. There's some that had previous operations on the aortic valve leaflets. I think actually when you drill down into the results of valve spray and root replacements for bicuspid aortic valve disease, it's not as good as for tricuspid aortic valves, I think, even in the best of hands.
Yep. Okay, so I think there are no more questions.